Our next panel is focused on AI in residency and fellowship training programs. Our moderator is Professor Adam Rodman. Adam is a practicing physician at the Beth Israel Deaconess Medical Center, an AI researcher, and somehow he manages to be both a historian and a futurist. Adam has written some of the seminal papers on diagnostic and management reasoning abilities of large language models, and he's also heavily involved in the teaching of residents and fellows. Adam, please take it away.
Thank you very much, Dr. Menrai, and a huge honor to be here. What an exciting time in medical education. I would like to invite up my esteemed panelists because this is going to be a lot of fun. So come on up, you guys. Oh, there's Scott. So like Dr. Menrai said, I am a general internist at Beth Israel, approximately 500 feet away from here. I was actually teaching some of our residents this morning, so very excited to be here. I would like to start with Dr. Williams at the far end to introduce yourself and why you are, not why you are excited, but what are your hopes and fears for AI in your field? And then we will work our way down to Dr. Pugh.
Fantastic. Thank you so much for inviting me to be a part of this panel. My name is Molly Williams, and I'm the executive director of two programs here at HMS, the Family Van and Mobile Health Map. The Family Van is a mobile clinic that's operated in Boston here for 32 years, and Mobile Health Map is a national effort to help mobile clinics measure and communicate their impact. So what I really hope to bring to this panel is the perspective of the community and the patient. And that's because I think my greatest hope for AI is that it will help us reduce disparities and to bring care to people in a person-centered way that reaches and helps people who right now are really disenfranchised from the healthcare system. And my biggest fear is that AI will widen the gap between the haves and the have-nots. With that, I'll pass it.
Hey everyone, I'm Eileen Reynolds. I am a general internist. I'm not exactly sure what expertise I bring here today. I think I am maybe an average leader in an academic medical center dealing with the spectrum of medical student through august, renowned faculty members and all that that brings with it. I'm the chief of general medicine at Beth Israel Deaconess, which does technically make me Adam's boss.
Yeah, that context here is she is my boss.
I oversee a faculty of more than 200 general internists in primary care, hospital medicine, palliative care, and in research. I'm the former program director of a program of about 160 residents. And I also am the faculty dean at one of the Harvard undergraduate houses, and so I am an in-residence faculty leader for about 450 undergrads. And I have thought about AI in all of those, in all of that broad spectrum of student to lifelong learners. I think that my greatest hope as a general internist and primary care doctor is that AI might actually help me continue to be a broad-based provider of equitable primary care and to help me manage the incredible burden of knowledge and data and inputs that I need to have in order to take the best care of my patients. I think I have many, many hopes, but the simplest is that it actually helps me do my job better and easier for all patients. My greatest fear is that it will actually produce additional divides between care we provide in the US and abroad, care we provide between different populations here in the US, and in some ways, care that is provided by different generations of people in the United States. So I'll leave it at that and pass it to my colleague, Dr. McDonald.
Thanks, Eileen. Furman McDonald. I am One day into my second month as president and CEO of the American Board of Internal Medicine. Prior to that, for 10 years, I was the senior vice president for academic and medical affairs there because of my background in graduate medical education and our work with discipline-specific governance. My background is really in GME, and that's where most of my research and scholarly work has been. I served with Dr. Reynolds on the review committee for internal medicine of the Accreditation Council for Graduate Medical Education, this group that oversees residency and fellowship training. And I also led an internal medicine residency of about 168 residents when I was at Mayo Clinic for those 10 years prior. My greatest hope, actually, for AI is that it will be beneficial to our patients. It will help enhance the quality of healthcare as we work together to do that, and that's ABIM's mission, to enhance the quality of healthcare by certifying those who demonstrate the knowledge, skills, and attitudes essential for excellent patient care. And so from that angle, I'm really hopeful that AI will help us be able to demonstrate that, in particular around the assessment of competencies other than medical knowledge. We have 6 ABMS ACGME core competencies. One of them is medical knowledge, another patient care, which we have some, our judgment, which we have some insight into. But the other ones, we don't do a great job at assessing, like communications. And patients tell us that communications is actually one of the things they value the most in their physicians. And could these emerging technologies help us do that better? Could we look at artifacts of care? Are the technologies now such that we can process artifacts of care from physicians and actually be able to give them data back that would help them improve the care of their patients? What's my greatest fear? It's not that the AI will be able to pass the assessments. That's not my greatest fear. Actually, it's not a fear at all. Mine is probably something I think that Bill Gates said, that when you introduce technology into efficient systems, you tend to make them more efficient. When you introduce it into inefficient systems, you magnify the inefficiencies. And in American healthcare, that's a real risk for us, and I think we need to be cautious of that when it comes to AI.
Hello, everyone. I'm Carla Pugh. I am the Thomas Crummell Professor of Surgery at Stanford University, and I am also the Vice Chair of Innovation and Director of the Technology-Enabled Clinical Improvement Center. I am also currently on sabbatical from Stanford, and I'm the Presidential Leadership Fellow at the Joint Commission for Healthcare Quality and Safety. My research focuses on the use of sensor technology to quantify human performance. And I'm particularly interested have been using this technology on students, residents, faculty, anyone who will allow my team and I to instrument them, and it's been thousands over the past 20 years. And for me, it's been exciting to look at, in a digital form, what does good care look like? How do you do the best physical exam? How do you do a bedside procedure or an operation? And to digitize that and look at what's common amongst different practitioners and where the differences are and how it all relates to the best outcomes, whether for the patient or just the procedural outcome. Did you make a diagnosis? And if you failed, what were the variables that we can tell from the sensors, whether it's a force sensing resistor, motion tracking, EEG, audio, video? We synchronize multiple data streams to quantify clinicians. When I think about, I'll tell you my biggest fear with AI. My biggest fear is that we will go boldly without the right data. So there's a lot of information out there, and it's awesome, and using generative AI to give us these amazing summaries in exponential fashion and, bringing it down to salient points. But at the same time, you realize partly it's inaccurate because the information is not there, and partly it's also inaccurate because it doesn't have the super nonlinear patterns of multiple different inputs that humans have. And so that's my biggest fear, is that, yeah, we don't realize the full potential. My greatest hope is that we will. My greatest hope is that enough conferences like this, where we talk about the pros and cons and what the opportunities are, that we land in a place where we're fighting for this to be the best that it could be.
Okay, well, I am so excited to have this conversation. We're going to talk about a lot of big ideas in medical training today, but I want to start with on the ground. So I'll have Dr. Pugh start with this question. But what do you see happening in medical education right now? What are your trainees using? What sort of tools are programs using? Or is a lot of this a very theoretical debate that has yet to really change the way that we practice medical education?
So I didn't mention, most of the time that I spend with students and residents is in the operating room. And so teleport yourself out of the classroom into an open abdomen, and I'm taking a student's hand and saying, yes, fill this tumor, or this is the liver, get your hand in there. And I think I know how they're using certain tools to look up information and to be more efficient when they're taking care of patients on the floor, to facilitate difficult diagnoses. But I think there's still an opportunity for other scenarios like situation awareness. When you're in the operating room and you've got a needle in your hand and you suture like this, and you see everybody standing around you pulling their heads back, that's because you're not paying attention that you're wielding a sharp object. So being able to digitize that and or give them that feedback that's understandable to them. So my hope is for precision education and use of that, but I don't know that those technologies fully exist yet.
Dr. Reynolds, are you seeing, as a program director, are you seeing many of your faculty or residents use AI technologies yet?
So Adam, I'm going to go back a step and I'm going to talk about undergrads, because the next thing they become after their undergrads is medical students. And I was having dinner, I vividly remember this dinner that I was having last year with a small group of undergrads. And we were talking about AI. And they told me with great certainty that Google was going to cease to exist, because they actually don't use Google anymore. They just open ChatGPT and do the same search that they would have been doing in a simple search engine in ChatGPT. And honestly, my head burst. My brain just burst at the notion that Google would go out of business because they weren't using it anymore. And so I brought that question to a lot of my interactions with residents and faculty members. How are you using AI? What are you doing in your practice? How are you using this every day? And I will say that the residents I interact with are using it every single day in ways that we don't even realize that they're using it. They're using it to write their notes. They're using it to, they cut and paste large portions of data from the medical record into ChatGPT and come up with a differential diagnosis. They make their slides for presentations. They write birthday cards to their family members. They are using it all the time. When I talk with my faculty members, there is a sort of a diminution of use with each additional decade of life. And many faculty members really are unaware that the learners that they're working with are using so much AI in the daily activities that the faculty members are overseeing and supervising. The faculty, my suggestion to them is that they open up ChatGPT on their computer and that they get used to starting to ask queries and start to learn how to use it, because they are supposed to be overseeing the work that their learners are doing and their trainees, the care they're providing. And the faculty really have little, most faculty, not all faculty, but most faculty have little experience in this area.
Dr. Williams, I have a question for you. I wanted to touch on some themes that you brought up in your comments about patients interacting and how your staff in the mobile health van interact with patients who may themselves be interacting with AI. So how are, and this will then be for everybody, but how are you seeing your staff, how are you seeing physicians change the way they talk to their patients, knowing that their patients are using AI? Have there been changes in the medical encounter? And is this something that we need to start addressing in medical education?
Really good question. So I think just to give you a little more context, our mobile unit here in Boston is run by community health workers. So these are people from the community who've received extensive training, but they're not licensed clinical professionals. And so we do screening and education and connect people to resources, which sounds very simple, but is actually requires deep listening and deep conversations. I don't believe that many of our clients are currently using AI at home, but honestly, we don't know. What we do here is, we're very fortunate here in Massachusetts because more than 90% of residents have insurance. We have a great network of community health centers, and most of our clients on the family van have a primary care provider. That doesn't mean that they understand the diagnoses that they have or how to stay healthy or when to go back to the doctor. And so what we hear from them is not that they want more care or more advanced care, more technological care. They want better communication. And so the hope that I have for AI is that it can help us, not just physicians, but community health workers and anyone who's interacting with a patient, to communicate with them in a way where the patient feels heard, feels heard, and is also that communication is tailored to their specific needs, whether it's language. ChatGPT has surprisingly, I shouldn't say surprisingly good, none of it should be surprising anymore, but has excellent translation capabilities, is really good at taking things down a grade level. I do that a lot, like, okay, that's really good, but could you please reduce that paragraph by 3 grade levels? And then cultural values as well. So I can tell ChatGPT, I'm communicating with someone who values family and community. How might I tailor this message? So there's, I think, great opportunity to use these tools to improve communication if done right.
So I'm going to throw the follow-up to Dr. McDonald, because you also mentioned one of ABIM's mission is to do more than knowledge assessments, right? To get other domains of what it means to be a physician, including patient communication. So before talking about what the ABIM wants to do, I'm curious about your opinions. How should we be teaching our trainees, or should we be teaching our trainees to use language models to improve patient communication? Is this something that we should be looking at now? And after Dr. McDonald, I'll throw that to the rest of the panel as well.
So I'm going to say affirmatively that we should be teaching our trainees how to communicate better. And insofar as these models can help us do that, then yes, we would be wanting to use them. Around your question of patients, so I was just in clinic last week. I haven't seen patients, at least in the demographic that are at the J. Edwin Wood Clinic of the Pennsylvania Hospital where I precept, coming in with ChatGPT readouts. I have seen residents using open evidence and other approaches to that. So, Adam, I think from a GME training standpoint, I would say we ought to be exploring these and utilizing the ones that actually demonstrate improvements in learning outcomes.
To all the panel, actually, this may be a great question for Dr. Pugh. Have you seen any technologies that are being used to help improve communication or provide assessment of communication?
So I've seen a few. Wow. We're not where we could be. So some of if you think about what we currently use just with interpreters, we are now able to have some of the, instead of just a language interpreter, really get to the detail of what the patient meant, or taking some of the vernacular of what they're saying and helping us to understand from a patient-reported outcomes perspective, what patients really want. And if you think about it, you step back, for us as physicians, we're trying to get information about what brought them to the hospital or their disease and how they're feeling so that we can get a diagnosis. Once we make a diagnosis, we're happy. The patient, on the other hand, wants us to spend more time speaking with them about what their life is going to be like. And so that's where some of the tools that I've learned about that are being used, or the researchers who are trying to figure out how to integrate patient-reported outcome measures into the EHR. And so working with Epic and some of the Microsoft AI Copilot things, that's where I see it being used. Haven't seen it be super effective yet, but integrating patient-reported outcome measures into the EHR.
Anybody else have on the panel, any insights into this?
I want to add just one thing. When I think about communication, we're often thinking about, well, where's the patient coming from in this interaction? But I think it's also important to remember that the physician has a point of view and their own strengths and weaknesses as well. And so an example that really stood out to me as I was thinking about this panel is my son. I have a 9-year-old son who's autistic, and most of his autism shows up in the form of social challenges. So reading social cues, perspective taking, reading a room, those are really challenging for him. And so what happens is he ends up in situations where kids are teasing them. He's in 4th grade. This is what kids do. Kids tease him. He doesn't know that it's teasing, and then all of a sudden it escalates. And it's really painful and hard for him to manage, hard for me, of course, as his parent to manage. And so recently I was on ChatGPT, and it has the window on the side that says like a little title of the chat. And so it said something about bullying. And I was like, I don't remember asking ChatGPT about bullying. And I went in, and my son had asked ChatGPT, what do I do if someone calls me a dumbass? It's like, wow, okay. First of all, ouch, I'm sorry you had that experience. Then I looked at its responses, and they were really actually helpful. And just the fact that, one, he's 9 and he knew to go to ChatGPT, but 2, that he knew he could get help with a communication challenge, a social challenge in that moment. And it's not just for people with autism or others or diagnosed communication challenges. We all have our strengths and limitations when it comes to communication. And so I think it can be a useful tool for practitioners to say, okay, I'm going into this conversation. I know I'm really analytical, and the person I'm talking to is very relational. How can I frame this topic in a way that allows me to be heard and for me to hear them? So I really see the value in this, not just for the patient, but for the provider as well. Thank you.
I think just to tag along on that concept a little bit, Adam, I think your original question was about communication and training for communication. And I think it's related to this, the fact that there are chatbots that are considered to be empathic, to be acceptable as therapy providers. We have an enormous need for mental health providers in this country, and certainly at younger levels, there is an opportunity to provide what I would call real communication and empathic listening from an actual chatbot when there are inadequate resources for mental health care in the community. And I think it's been challenging a little bit for me as a primary care provider who I pride myself on communicating with my patients to understand that sometimes the chatbot might be perceived as being less biased or more empathic than human communication. And how we teach about communication is, I don't think we know how to teach about any of this yet, except that we need to teach about this. But I think that in some ways we may wind up using some of these tools to actually do some of the teaching, which is like a little bit of a meta approach.
So coming off of these ideas, this first question will be for Dr. McDonald and then Dr. Pugh. If you think about what we do in medical education, teaching is a large part, but assessment is a huge part of our jobs. And speaking for myself, I find assessment to be one of the most challenging parts of my job. So starting with you, Dr. McDonald, especially from the ABIM's perspective, or from a medical board perspective, what is the role in these technologies in assessment and in making humans better?
So thanks, Adam. I'm going to actually take Dr. Reynolds' approach and step back from the board and actually go into the GME space where I have some experience. But I do this because your question actually, I was just at the Association of Program Directors and Internal Medicine fall meeting in Minneapolis. And I went to a session on just that question. And there are some really innovative educators out there using these technologies for assessment in ways we might not realize. So many of you, if you're in GME, you know about the milestones. You know that these are developmental frameworks for narrative descriptions of our course of development across the competencies and the sub-competencies, if you're into that world. It's been really, really hard to get faculty to be able to rate residents on these milestones. And so, and this is coming to where I think these especially these large language models have some real opportunity. So this one group, they brought up and they just said, you know, we're going to stop asking our faculty to rate people on the milestones. We don't want them to even be oriented to the milestones. We want them to just give us the narrative of what they just saw. Like, just describe what you're seeing in the learner. Describe their growth along the curve. Just put it into English, right? Just give me, and then they put it into the large language model and say to it, here's what the competencies are. Here are the narratives across all the sub-competencies. Here's the description of the faculty. And oh, by the way, here's the description of 50 faculty who've observed this resident. Now put the resident along the continuum of the milestones. And it does a really good job. It actually is really good at assessing language, and so to me that's a great way to use these models, especially those that are structured around language, right? I think surgical training has another challenge, right? And I won't even speak to that. I'll defer to those more expert. But I think that this is a real opportunity for us with regard to the assessment of the physician in the GME space, which is, by the way, the most high-stakes decision in the board certification process. It's not, you know, people talk about the high-stakes initial certification exam. That's not the most high-stakes decision in the certification process. It's the decision of the program director and the competency committee with regard to the eligibility of the candidate before they ever go sit down, because 89% of people are going to pass on the first time. 97% will pass within 3 attempts. So it's getting to that point that's the most important. And I think these models have a real promise to be able to help faculty and help program directors with their faculty. We had all this faculty development for years, trying to get people to be able to put them on the milestone continuum. And this idea of just stop, just tell me what you saw and let the large language model assign it to the milestones, I think is really exciting.
And Dr. Pugh?
No, I reiterate that. You know, I've worked with the American Board of Surgery as well as the Blue Ribbon Committee, which is a group of leaders in surgery, and we just had a multi-venue review of where do we go next. And there was this pivotal moment as we're discussing all the difficulties of training and all the things that we could do in the future with technology and AI. And we realized that everything that was wrong with the training, we then came up with an idea for the faculty to take care of. There's no room to do it. And so the thought that you can use technology to facilitate, and I'll give two examples. We also have the milestones and then entrustable professional activities, EPAs. And it's the same problem. It doesn't matter whether you put it on the cell phone app to try to make it accessible. You're still adding something to the list of things for a faculty person to do. And it just doesn't get done until the residents don't get feedback. One of them does have a voice where you can, just as you said, verbalize what you just saw. But I'll take it to the next level, and that has helped where we're collecting now faculty feedback that they dictate into the app before they leave the operating room in terms of the residents' skill. One of them is a standardized app where you click the level of difficulty and then of the case and then the level of independence of the resident, and then you dictate. We put sensors, motion sensors, in a simulated environment on 100 faculty and about 70 residents for 3 different operative tasks. And long story short, the actual motion data, when you put it into an AI algorithm, it is actually able to predict the simple app ratings that you would get from the operating room. So we're excited. There is an opportunity to take other data. And so you think about just what you're observing, the verbal feedback you give, but there's a lot more happening in terms of what the residents are seeing, why they act, and that motion gives us some really interesting information that can be processed. And it does relate to human observation. So there's an opportunity.
That's really cool. I mean, as a general internist, the idea of doing surgery just gives me palpitations to think about it. Now, as internists, we're a cognitive specialty, so the electronic health record is sort of our equivalent of motion tracking. I'll throw this one to Dr. McDonald first, but do you think there's an opportunity to use the artifacts of medical care or documentation to provide feedback to both residents and even potentially at the CME level?
Yes.
That was a yes/no question. I shouldn't have asked that.
The answer was yes. Actually, I think it's one of the more exciting things out there, right? So we're generating all these artifacts of care every day in our clinics. Our residents are generating them. We are generating them. Honestly, the faculty are writing notes on the resident notes, and we could give them some feedback as well. And it's the ability to process these really large volumes of data in a way that can give actionable feedback back. One thing I'm really looking forward to is the day the LLM tells everybody that, hey, did you know that your note is connected to like 700 notes behind it from the copy-paste function that you used on your... So absolutely, and there are many people out there working on this right now, and I'm interested to hear what the other panelists have to say.
Well, I would argue, Furman, that the notes are actually not the right data that we seek, because many of those notes are just like the old copy-paste. The notes are actually going to be created not by the individual person who's seeing the patient. Rather, the actual language, some of these ambient listening models, if there is a way that there could be an assessment of the quality of the communication, of the history taking, of the explanation and patient education that's being provided in the encounter, that would actually be a really fascinating way to start to get at issues of competence. But how to subtract out in the future what is the individual and what does the individual know versus what is augmented by however they're using language models or AI in general, I think is going to become increasingly challenged.
Yeah, please.
I absolutely agree with that. And actually, as you were speaking, I'm like, well, what would really be cool is these models actually help us more accurately describe what really did just happen in there, rather than, why are we taking the physician's time to try to reiterate this when we potentially have technologies that could help us do that, and then give the physician feedback on where, hey, you maybe should have done that part of the exam that we didn't do, or maybe you should have had that conversation, and especially feedback on our actual communications, coming back to that theme here.
Yeah, just a side note, we transitioned to Epic on June 1st. And to think that a note that I am creating in the chart bears any resemblance to the quality of care that I am providing is, I just hope nobody is assessing the quality of my care based on my first 3 months of Epic Notes.
Yeah. It makes me hopeful for, the folks that are doing ambient recording of what's happening. You get both what the physician is saying while they're talking to the patient, but you also get what the patient says. And I think that will take the data that's in the EHR to another level in terms of good information. As you all were talking, it also reminded me not only the notes, but even for me, I spend a lot of time reminding my residents and trainees that a CT scan is a static picture of a dynamic process. And so when you were coming up with that decision, what point in time did the CT scan enter, and now you're talking to the patient how many hours ago? 24, 36? And the further out, then the less accurate you are with coming up with what's the right thing to do, especially with the patient's symptoms. Had the patient's symptoms evolve? So I still think of the huge opportunity. I think what's currently in the EHR, like you said, I think, wow, it's really just partial asynchronous representations of what we've done, but it's highly processed information. You took in all this visual information, same in the operating room, a 4-hour operation, and I give you 2 paragraphs. You don't know what I did, what I saw, and why I made those decisions. Same thing at the bedside. So I feel like there's a huge opportunity to get more accurate data. And I'm back to what I said in the beginning. My biggest fear, we will go boldly forward with not enough information, and it's going to be garbage in and garbage out, and we won't get to where we want to be.
So a final question from me for the panel, and then we're going to open it up to everybody else because this is an amazing group of experts. Dr. Williams, this will start for you and then to everybody else. We've talked a lot about our hopes and what we're optimistic about. So what are the barriers? Like, what are the barriers getting in the way of this future? Are they primarily technological barriers, or are there social barriers in the way of bringing in a more optimistic future for med-ed with AI technologies?
So I think from the patient perspective, we often talk about access to care. And access, I won't go through them all, but we think about it as the 5 A's. And one of those is acceptability. So will these technologies, will the use of AI in the exam room be acceptable to patients? And having them at the table during these conversations, figuring out how that gets integrated into an EMR, into an exam, is essential to this. And part of the challenge in doing that is that things are moving so quickly. And even, I use ChatGPT every day, and I read blogs and books and really have been trying to keep up, but even I can't keep up, even though I'm dedicating time to it. So I think that is a huge barrier. And then the other one I'll just mention is we already have a huge digital divide in this country across race, class, generation. And so who's going to use these, both from the patient perspective and the provider perspective? I think someone mentioned generational differences, and making sure we engage the people who are going to be using these tools, regardless of their current level of comfort with the tools, is really essential to making these benefit people and to reduce inequity.
I really appreciate your perspective there. Thank you. What are the barriers? I can think of many barriers. I think the barrier that I'm most concerned about right now is that it's a little bit like the Wild West, where everybody is doing everything from a kind of shotgun mentality. I worry that we don't know enough and we're not looking enough at what the impact of the way we're using these technologies are on both patient outcomes and on learners. And I think that everybody just going in a million directions is not allowing us to learn what the best approaches are. I will relate it back to Epic a little bit. I think at the beginning of electronic health records, everybody thought that they would transform the way we care for patients. And I think we all have probably seen that there are many values to electronic health records, but there are also many cautionary tales about how they have driven excess documentation, chart bloat, billing practices that had unintended consequences on finance and economics. I just am concerned that we have unintended consequences because we're not watching.
So one of the best definitions I ever heard about graduate medical education was from Tom Naska, actually, learning in the context of patient care. So these innovations that are coming, there's a vanguard of people that are really involving them, but they're going to run up against the buzzsaw of what we have to do day to day to make sure that we get the patients seen in the clinic, and how many do we have to see, and what is the billing requirement, and all of that. They will increase as the diffusion will increase as it becomes more helpful in that process. But I think the risk is there in my comment from the beginning that introducing technologies into inefficient systems can magnify inefficiencies. So I think that's one of the real challenges that are there. This is almost by definition a complex adaptive problem. You're perturbing a system, you don't know exactly what the results are going to be coming out of it. I think taking a long view back, I think we're going to see some improvements from this, but it's also going to be messy as it's introduced, and I think we're beginning to see that now. The hype curve, if you will, of some of these technologies is beginning to go down some, but I do think it's going to pick back up and be overall positive in the long run.
Yeah, you nailed it for me on the complex adaptive system. And I think where we are, the biggest barrier for us is that we have this technology that has this amazing potential. We're seeing it, we're using it here and there, but we are not changing our traditional workflow and existence and able to allow us to use it, learn it, and adapt. And so there are a few folks talking about it, but it hasn't happened yet that we have an AI specialist or IT clinical specialist that's part of our team when we make rounds. Like, we have to change our traditional workflow in order to allow us to talk about the technology and use it.
Okay, and I also want to say for everybody listening online, if you have a question, we are going to have a human-computer interaction, so put it in the chat and we will have a human provided here. So yes.
Thank you very much for this panel. It's very intriguing. I'm not a medical professional by any means, but I'm very much intrigued by the idea of who is building the models that you use today to be deployed in the future. And it strikes me a little bit like all I hear is like MDs are very, very tight on time. It takes years and years and years to become specialists. And then when you do become specialists, there's not enough good people to see the patients. And so who's training these models? And who's deciding what data goes into these models? And who's vetting these models? I think I'm always struggling in my mind between the compromise of like not serving patients today with the idea that you're vetting these models and helping build them so that the impact in the future reaches many more people. So how do you think about balancing short-term gains with like long-term impact, knowing that some people might die today because they can't see the right people, but many more people can live in the future because people took the time to build the right models today?
That's a really important question that I feel completely not able to answer. I will say that a part of my concern about unintended consequences is that we're not learning from what we're doing in a way that will help us identify the best strategies. And what's a little bit behind that comment that I made is that there are venture opportunities to deploy these for big money that are galloping away in many locations without as much study as we might like there to be. That's a gross generalization of your question about specialty care, for example. I think Adam has a fair amount of, if I can defer to the moderator, Adam has a fair amount of experience in trying to start opportunities to study the implementation science of AI is a fascinating opportunity for the future. We're building a small, what we hope will be nimble primary care practice that will be able to rapid cycle innovate. But Adam, I wonder if I may take the prerogative to defer to the moderator.
So it's a fantastic question, which I think cuts to the core of many of the challenges here, which are the people who are building these models. So they're very powerful models with many uses, but they're not necessarily being built by people who are clinicians, which is fine. But when they're being deployed, they're not necessarily being deployed or evaluated by people who understand what is good care. How do we measure and understand good care? My opinion, so I think this is a huge problem, and I work very closely with my colleagues in the Department of Biomedical Informatics, and at BI now we're actually joining up our residents with data science students at MIT. I think the future to operationalize this is to get doctors and computer scientists and data scientists working together. And there's no way, I don't think we can expect doctors to build models. We have to know so much, and you want me to learn linear algebra? No, thank you. But what we can do is have doctors work fairly closely with people who are very good at building models. And I am cautiously optimistic that that's the way forward on this. Okay, next questions?
Hi, thanks everybody. We've talked a lot today about us learning from AI or AI models being used to teach, but it occurs to me that simultaneously AI could be learning about you. And just as you click something on Google, it knows what ads to show next, that because it's learning your behavior. AI, which is far more powerful and can look at millions of associations to draw conclusions, can figure out unrelated things about you. If you interacted with it in a certain way, you have more of a tendency to take a loan, for example. If you interacted in a certain way, these people will go on to be pediatricians as opposed to surgeons when they interact with the training bot in such a way. At what point then do we start thinking about the sort of Orwellian implications of it when, if you're a program director, is the medical student's interaction with the chatbot discoverable to decide if you want to give them a position? If patients interact in a certain way, is there a way to figure out whether they are a good paying risk or not? So it's all great that we're learning from AI, but at what point do we have to start thinking about these large algorithms can learn about you and typify you and draw conclusions that could become detrimental to you? Can you talk a little bit about that?
So, yeah, great question, great point. You're absolutely right. These models, almost by definition, are learning as they go, right? That's what large, and I'm struck by the training environment. So we've got recovering program directors on the stage, and right now we're attuned because there's something called the Electronic Residency Application Service that just opened up within the last month for our program directors to download thousands of applications, literally thousands for each program, and a lot of push towards holistic reviews, not just making decisions for who gets into residency based only on test scores. I don't think they were ever only on test scores, but emphasizing their other attributes, including their personal statements. And I do know of programs that are out there testing this right now on how do they use these models to siphon through, thousands of different application statements. And then what's a little scary is I'm not sure we really understand how these models are doing that in a way that we're interpreting the data correctly. And I do believe those that I know are using it are taking appropriate safeguards, and they're testing it, and they're trying to actually learn from it. I'm really agreeing with you that I think there's a much unknown here, and what kind of safeguards need to be put in place, especially as we get around the assessment of physicians for each step along the way. I mentioned the med student to residency transition. What are the human protections there? Are protections for humans in this process, I think, is something we as a community need to wrestle with.
I have to say something because I'm shocked with what is happening in my brain right now. I mean, thinking about your question initially, I was like, yeah, this is really bad, And I'm like, well, actually it's not. And it just makes me thoughtful that we should actually, if there's all of this, we know there's a lot of information out there. We should have a moratorium on judgment based on things that are in the internet, in the unknown. And then that makes actual human to human interview more important than us sleuthing and looking at things that people said and posted and questions and making judgment. The reality is we've never had that information before. So who are we to pass judgment? I think there should be a moratorium on the judgment. We have to accept human behavior. I don't want to talk long, but it just reminds me of there was some senator in the wherever she was, who went to a party. Oh my God, and she was then blasted all over the internet for being at a party and getting loose. Oh my goodness, how many of you in the audience have never been to a party? And then who are you to judge? Please, we're gonna have to become more open, thoughtful human beings and not pass judgment based on what we find online.
A moratorium on the judgment. Once these are large enough and the data becomes widespread enough. And
Well, I would say that there actually are protections in the training environment that prevent programs, don't allow programs to share training assessments and training evaluations with fellowship programs, with potential employers, even with the ABIM. Once you've signed the line that says capable of practicing independently, we do share a lot of information with the ABIM, but there are protections on that as well. The state in Massachusetts is allowed to request some training assessment information from programs, but generally speaking, there are lots of protections against giving or providing information about judgment within training outside of the program itself. And whether we need to think about whether those protections need to be spoken and standardized for electronic assessments within the training environment is true. What's the future about all of those websites where patients post their reviews of their doctor, or how might there be, beyond the training environment, additional judgment in the public sphere is a really interesting question too.
All right, next question, please.
Asia Zimmerman, I'm a transplant surgeon from Dartmouth. There's been a lot of talk about the democratization of knowledge and information, and I'd be remiss not to ask such a panel of experts and people who have real influence. These training models or these language models are trained on a corpus of open access articles, right? And we talked about the bias of information. And so if you guys had a magic wand to alter that, what would you do? And more importantly, what should we do practically to try and improve the training sets that these language models are trained on?
I'm not sure that I have the answer to, I know I don't have the answer to this question, but I have been thinking a lot about this concept of democratization. And, like any democracy, there are variations in terms of participation. And some people are very involved, vote, very civically active, and others are not. And that's shaped by cultural norms, societal norms, economic and social constraints on who can participate. And so this is less about the learning environment and more so about the community environment and who can participate in AI. And I think, is it really democratizing, say, health information or access to health care? I think that remains to be seen. But I also think it's up to us to make it happen or to advance that ideal. Because you think about in the US and efforts to expand voting rights and to get out the vote, that's about That's about advancing our democracy, and it doesn't happen by itself. So just like our political democracy, we need that same level of advocacy and engagement, grassroots level that says, are we democratizing this? Yes. And so we're gonna be the ones to make that happen.
Okay, we're in the last 5 minutes. Let's get some online questions.
Yep, I'm Payal. I'm the graduate student human in the loop. So we have Professor Tina Austin from UCLA asking, what about data privacy issues and who would own the data if you were to use large language models in healthcare?
Are you guys looking at me? So from an actual implementation standpoint, all of these are going to be done through enterprise agreements where the training program themselves or the hospital or health system owns the data. No one, I'm sure that there are tech people watching, no one is going to sign a deal where the tech companies own the data that is produced by training programs. I think that goes without saying. Would that be a unanimous head nod? Easy. If you use the API through OpenAI or use the chatbot, they do. But if you have an enterprise agreement, it's negotiated out. They do not. So like the Harvard has, HMS has an Azure instance. They don't own your data. So when these things are implemented, they're not being implemented in ways that the tech well, I assume, I can't speak for anybody, but I assume that these enterprise agreements are not allowing ownership of the data.
I got into data science when I met Dr. Joy Buolamwini at MIT Media Lab, who is very famous for her work, Coded Bias, and she runs the Algorithmic Justice League. And then I started working at Boston Children's Hospital, and I started teaching everyone there, 24,000 employees, how to use ChatGPT. And it was very interesting, right? Because it so quickly could help write prior authorizations, and it really reduced a lot of inefficiencies. But when we started to discuss the ethics and the way that we could fight some of these inequities, the issues that we were running into were things like if a 2-year-old bit a nurse, and that nurse then wrote into the electronic medical record that that 2-year-old was aggressive. And then later on, that child is nonverbal and being seen, and of course, all behavior is communication. And so then there's a behavioral thing, and then a doctor writes in difficult, and you can see how over time, there would be all of these negative words that show a bias towards this one patient. And if we decide that we're going to take, say, 50 words, say, because it's a large language model, we're going to take the words aggressive and we're going to take the words difficult, and we're going to change them all to non-compliant, then that means that it's fair, right? So then I think of my own child, who is 17 and has had over 25 surgeries, is medically complex, and goes to the doctor for 90 visits a year. And as she's now heading into adulthood and switching into adult care, I can see how now at Boston Children's Hospital, we have our own HIPAA-compliant ChatGPT, and they're using it to write really good narratives and histories of these patients. So what happens if there is the word non-compliant in an electronic health record, and it's written, say, 50 times, 60 times, 70 times, and then later on, the adult needs a transplant? And one of the qualifiers for that transplant is, are they going to be compliant with a complicated medicine, anti-rejection medicine regimen? And if you use that large language model and what fed into it, and it turned up the word non-compliant that many times, it is possible to see how that adult patient would be removed from that opportunity, from having that transplant. So then, when Boston Children's Hospital released their own ChatGPT version and their own HIPAA-compliant API, I asked for transparency, and I wanted to know, with all of the record keeping and all of the textbooks that have so much racial inequities and all of this bad data, can we find out what is being fed, what were the decisions made on these words? And it was crickets. It was just science, absolute silence, and nobody is revealing or being transparent. So when you are now teaching with residencies and fellowships, and you have all of these wonderful bright minds, Do you ever discuss the choice of the words, knowing that we are going into a large language model world and what those words could mean for these patients over a period of time?
So unfortunately, we are out of time. It is the end of the panel. I believe there's a panel coming up next. Thank you for the wonderful question and anecdote, though. I wish we had time to discuss that. I want to thank everybody on the panel. All of you, thank you so much. And we will welcome the next panel.